we are really not done in regard to checkpoint inhibitors because, as already Peter suggested, so we are really focusing quite a bit on anti-PD-1. And then there's the anti-CTLA-4, where everything started was, with Bruno Sangro first study that was reported a few years ago. And now, out of nothing, we have a new study, the Himalaya study, which I'm honored to chair, but I would love to hear your thoughts on that. So.
Yeah, so for those who don't know, so the Himalaya trial is evaluating basically single agent immunotherapy versus dual agent, so combining PD-1 and the CTLA-4. And this goes to Peter's point where it's not just single agent immunotherapy. It's really now looking at doublets, triplets, et cetera, in terms of seeing if we can take that 15% and maybe by using PD-1 and CTLA-4 in combination, can we get these response rates higher? Can we make the survival even longer? And so, the Himalaya trial is evaluating this combination, dual agent versus single agent versus sorafenib. I think that there's a lot of hope that this will boost these response rates and the survival even further. So we'll see what the data show.
No, absolutely. The Himalaya study is really dependent quite a bit on the fact that a lot of the anti-CTLA-4 activity will happen at the lymph nodes levels, and then the activation of the immune system at this point will come to the anti-tumoral effect of the tumor per se by the anti-PD-1, and that's really where the combination might really play a major role. The Himalaya is a very large study looking at two variants of the combination of the durvalumab and tremi versus single-agent durvalumab as an anti-PD-1 versus sorafenib as the quote-unquote standard of care. So we'll see where this takes us. But Riyadh, not to kind of really try to steal the show here from all the great stuff in IR, but leave alone all of this, and then I'll bring you new information here that we heard at ASCO at a poster about the combination of atezo plus bevacizumab with a response rate of close to 70%. Tell me.
Yeah, so I've done my homework. I've read that abstract.
Good.
And that's unfortunately, as you know, the source of some of this data. So I think it was about 30 some odd patients that were reported, and only about 20 or 21.
Yeah, I think there were 43 and reported on 23.
23
exactly.
that were valuable, and of those, there was a 70% response rate. So again, one has to wonder what happened to those other ones. Maybe it's not follow-up. Maybe they didn't. There could be many reasons. Having said that, again, I think what's exciting about this is the message that I hear is this response rate. That's the common theme, is that people are seeing very high response rates and they want to combine these. My history with treating with bevacizumab historically has been a less than impressive one in the embolotherapy world with adverse events that were unacceptable. So it's interesting to see sort of a reintroduction of Bev in this field. But the team from Yale has reported on this, and again, they're very excited about the response rates, and we'll see. I mean, again, this is just in abstract form.
So let's talk a little bit about the science before we talk to a little bit of the intricacies of the study. And the question that I have for you, Peter, is there any scientific argument why a combination of TKI and checkpoint inhibitors will make sense or not?
Well, this particular combination, anti-angiogenesis with a monoclonal antibody and immune oncology makes, in fact, more sense than you would believe at first glance. The point is that anti-angiogenesis has dramatically changed in our scientific understanding. Initially, we felt, well, this is shut off of the blood supply and the tumor has no nutrients. Then we learned it's above shutting off blood supply, it's normalizing vasculature. So the aberrant vessels become normalized. And now we understand that it's actually interfering with the immune system. And aspects such as antigen representation, endothelial function in the immune system are also addressed by interference with anti-angiogenesis. So we are altering in a complex way the micromilieu of the tumor. That's one thing. The other thing is you cannot predict. These are two substances, bevacizumab and atezolizumab. Both have been, as single agents, relatively unremarkable, not very active. In combination, best results we have ever seen on a small scale. So I think there is a rationale. It's a complex change of the micromilieu, of the tumor micromilieu, and that is increasingly coming into our attention, is probably the backbone of future treatments.
Fair enough. Tell us a little bit about that data that Riyadh mentioned on atezo plus Bev. What is your best understanding is that the response rates were actually based on about half of the patients on the study. Tell us what are your thoughts there?
Yeah, so I think, Riyad brought this point up. They required people to have 16 weeks of assessment before they reported, and so you really end up with half the sample in terms of taking a look at these response rates. And you have to wonder if the response rates in the other patients that weren't included in the abstract are just as promising, or if this is a very selected group of patients. So I think that, like all these other abstracts in early form, I think that the data are promising. And this is actually shown by the FDA giving this, breakthrough therapy designation in the United States. So really pushing this forward, and I Am Brave now ongoing. But I think that it's too early to say that this is going to be it. I think that really, at the end of the day, this is a selected subgroup of a relatively small number of patients. I think we have to wait for larger data.
And if I can add one thing, Hassan, to what Amit is saying, in a matter similar to what I mentioned before with the immunotherapies, where we have the concept of pseudoprogression, one of the observations I've made with these anti-VEGFs is a transient reduction in flow in the tumor, such that when which you would make you call a response because it's less vascular, but then once that's discontinued, in a month, 6 weeks, that very same area is reperfused and revascularized. So I do think this area also is prime for studying the response concept, because I think in this case, vascularity, there can be transient changes. I've seen patients on sorafenib, stop the sorafenib, all of a sudden the vascularity is back within 4 weeks, but yet we called something response and necrosis, meaning it's dead, but then it's alive 4 weeks later. This is very important.
If I may add to that, Riyad, this is extremely important. What was promising, though, was that the assessment in the combination of Atezo and Beva was done by RECIST 1.1 and not by modified. So they were trying to pay attention to this temporary lack of perfusion, which is not meaningful in terms of response.
So if anything, we are hearing quite a bit about this, and clearly we can see the excitement even on the table over here. If anything, a combination of TKI and checkpoint inhibitors, even though, as Peter did really the best we can, and any of us would have done the same, trying our best to really interpret why. We really don't have a full understanding of that. We have notions, as we heard them from both sides of the table. On the other hand, number two is, as Amit mentioned, the idea about, if we could not assess that specific patient, then we don't include in the interpretation of the results, definitely is a little bit debatable. But nonetheless, because this is still a disease in need for new therapies, I think the advent of this combination, add to, by the way, several endless number of combinations. Now, as we heard, this is already in a phase 3 trial, but add to it, we have lenvatinib plus pembro, we have the nivo plus sorafenib, and et cetera, et cetera. There's quite a bit of different options that are evolving one way or the other. Actually, let alone the combinations, again, are, as we suggested in the beginning, are even bringing local and systemic therapy. For example, we should not forget about the FOCUS study that actually Peter and I are involved in, which really is trying to look into the vaccinia virus intratumoral injection that really has its own first direct cell lysis. Number two is an immunogenic effect, add to an antivascular effect, add to a combination with sorafenib. And this is also, add to the advent advent, which was already approved in the European market here by the EMEA for the therabionic spatula that can give a certain radiation correction, a certain frequency of wavelength through a better operated machine that the patient will put in their over their tongue, and then it will ultimately destroy tumor. And now there's already chit-chat and debate about what if we combine it with X, Y, or Z. There's quite a bit going on, which is really all fascinating, and we're really, if anything, remain very positive about really what are the potential opportunities for patients over here.